Hello everyone, my name is Jonathan Steven Andrade Bazan. I am a medicine student at UCSG University on 4th level. I'm going to talk about transplanting hepatitis C positive kidney. Let's start with definition. Definition. Kidney transplant is a surgical procedure that done to treat kidney failure. The kidney filters from the blood and remove it from the body through the urine. They also maintain your body food and electrolyte balance. If your kidneys stop working, waste build up in your body and can make you very sick.
People with implants can mean life or death, and kidneys aren't always available, leaving people trapped on dialysis with no end in sight. Because kidney transplants increase life expectancy better than dialysis, we offer several options to help someone in need of a kidney. The first option is finding a compatible live donor transplant. These are the gold standard kidney transplant procedures, since 97% are immediately fully functional. A donor kidney can function for over 35 years. Too often, willing donors don't meet the proper criteria. While live donors are still preferred, recipients can now receive a kidney with mismatched antibodies. If the wrong antibodies are present, the blood allergically reacts inside the patient organ. Remove these antibodies through a cleaning process called plasmapheresis, allowing for a successful transplant. Deceased donor kidneys are another option. These kidneys last 8 to 12 years on average. They're also typically reserved for patients who can't wait for a suitable live donor. The last option is a kidney swap. The system matches patients with kidneys needing incompatible live donors. While small swaps are preferred, swap chains of up to 60 people have had success. If you're in need of a kidney transplantation, speak with someone at our Kidney and Pancreas Transplant Program for more information.
Application in medicine. Kidney transplantation from hepatitis C virus positive donor to C negative recipient view and excellent sustained virological response. CVR red with DLT antiviral agent. HCV positive donor are being considered for the HCV negative recipient infusion center. We report the successful transplantation in a HCBC negative recipient transplanted with an HCBC positive donor kidney. Donor was treated with sofosbuvir and ribavirin.
I'm very happy to say that we've been able to implement the program successfully, ensure that our patients have access to organs that they might not have otherwise had. In my experience, virtually all folks who I've talked with before transplant, after hearing the pros and cons, have decided that it made sense for them to consider using such donors. I think we're all saying it's awesome. We see patients who have received and are doing well after an organ transplant who might not have lived to organ transplant if, for whatever reason, we had not had this program in place. I think none of us would have even had this discussion 10 years ago, but it's been made possible by the fact that we have multiple centers, it's safe and feasible, and that there has been this increase in the number of potential donors who have hepatitis C to consider and implement such a program. We're looking forward to continuing the process, broadening potentially this program to other organ transplants, again, ultimately living procedure.
That went fine. No problems with that, no side effects. And the Hep C responded well in 8 weeks, and I was done. It's totally worth it. Of course, I thought about it, but after all I've been through with the total artificial heart and matches by one antibody, because my antibodies were um, would have been say no. That's why I signed up, because it was getting to the point where I had to do something. Um, and 2 weeks later they found a match, and I sign up. Did anything to be afraid of. It's totally curable, and it drastically increases your odds of finding a match. Feels good to walk around and without putting all the time. Yeah, take outside and do what I want to do, and my truck, and do projects outside that I haven't been able to do. Yeah, feels good to get back to normal life.
Pros and cons. Pros. No more dialysis treatment. Greater freedoms. Less dietary restriction and liquid. Greater chance of living a life longer. Cons. Require major surgery with risk possibly related to surgery. You must take anti-rejection medication for the rest of your life or your kidney. Great risk of this medication.
In tonight's Healthy Living, perhaps a silver lining to a infected kidneys has actually increased because of opioid overdoses. With needle drug use, the hepatitis C infection is not uncommon, but thanks to new drugs available, those kidneys could be transplanted into patients with end-stage renal failure who also have Hep C. Stats show about 15% of patients undergoing dialysis for serious renal disease are also infected with hepatitis into consideration. Dr. Mark Ekman from the UC Division of General Medicine did computer analysis to ultimately determine this. It's better to wait less time for a kidney by getting an HCV-infected organ as long as treatment for the HCV follows transplantation. One of the reasons you cut dialysis time. Consider this. The non-infected kidney is typically 2.5 years. It's about 2/3 of a year.
You're saving about 12, 13% mortality risk by transplanting sooner. It's a way to guard these otherwise healthy organs. Treatable.
The UC study is one of a few happening in this area of medicine. At least 2 others have looked at transplanting a Hep C-infected kidney into a non-infected patient. Any strides made could ultimately reduce wait times for folks on the kidney donation wait list.
Relativity, direct acting antiviral agent that relativity offer cure rates exceeding 95% for the patient with CKD and patient with ACKD infected with patient C with hepatitis C virus had a significant effect on the retrievable and allocation of kidney from the HCV infected donors. The same with from viral donors. The transplanting community has studied the feasibility of using the effort to kidney transplantation.
Carr, and I'm Assistant Professor of Medicine and a transplant nephrologist at UC Health.
I'm Ty Dewan. I'm a Associate Professor of Surgery in the Division of Transplant. We have a lot of innovative thinkers to the point where we have a bariatric program for our recipients. We also have a telehealth program we have with Dr. Carr. We have a hepatitis C program that has really led to many more patients getting transplanted than would have in the past.
The major barrier that existed before positive argument was that we did not have good medication to treat the hepatitis C in the past. This with really good medication which can cure the hepatitis C with the rate of about 100, where we refer our patients after transplant and they treat these patients with the newer medication and make sure that they are cured of hepatitis C. Another barrier is these medications are very expensive, but we had experience from our liver transplant giving the donor and treating them afterwards. So we had the experience from them that the insurance will cover these medications. So we brought that experience over to the kidney side. Every one of our patients so far have the medications have been covered by.
And others that we do at UC to transplant these patients sooner. We had a patient who got listed for a hepatitis C positive organ, and literally within that week of being listed for that type of organ received their transplant. And these are things that not every program in the country does. Because we are at the leading edge of this by performing as many transplants, for instance, in kidney that we've performed, we know the ins and outs of this much more than the benefit experience that we've already attained. These types of innovations give hope to patients because it allows them to get off the wait list sooner. And if we can decrease that amount of time, which this type of innovation has allowed us to do, then we're really doing a good job. Truly, at the end of the day, both Dr. Carr and I and the rest of the team, this is what we come to work for every day.
Conclusion. Hepatitis C virus infection supposes an important health problem in a renal transplanted patient due to its negative impact on the graft survival. So the two main prognostic factors in the progress on infection. It's convenient to optimize the diagnosis and treatment of the hepatitis C carrier include the kidney transplant program for increasing the pool of receptor and avoiding the complication occurring after transplantation.
In the expander study, we transplanted 10 patients and treated them simultaneously with antiviral medications for hepatitis C. We had excellent transplant outcomes in these recipients and were able to prevent long-term transmission of hepatitis C from the donor to the recipient. To successfully treat all patients and prevent long-term transmission of hepatitis C from the donor to the recipient. They also had excellent outcomes following the transplant in terms of kidney function and recovery. Currently, are not utilized because the donor is hepatitis C positive and there's no appropriate recipient to place them in. Otherwise excellent kidneys, so we hope to be able to use them in recipients that already have a long wait for a kidney transplant and treat them with the antivirals that can successfully treat hepatitis C, and so along with treating them for hepatitis C to have both a successful transplant outcome and also prevent transmission of hepatitis C. We hope to take the results of the other patients waiting for heart transplants and lung transplants benefit from a shorter waiting time. And since there are organs from hepatitis C positive donors, both hearts and lungs, that are currently discarded because there isn't an appropriate recipient to transplants into hepatitis C negative recipients, treat them with the antivirals for hepatitis C, and have successful outcomes.
And that's it. Thank you for your attention.